Hi everyone and welcome back to Izzy Medicine. Today we're continuing our shock series, so let's start with our patient. A 29-year-old man gets brought in by ambulance after a motorcycle crash. On exam you see no significant external injuries and no significant external bleeding. He's talking to you, he's alert, but says, "I can't feel my legs." You glance at the monitor, the blood pressure is 82/48. Skin is warm to the touch, but the heart rate is 54. This is where you pause and ask yourself, bradycardia and trauma? Well, that's weird. Most trauma patients are in hypovolemic shock. They're cold, sweaty, and tachycardic. This patient, he's bradycardic and warm. This is when you start thinking about neurogenic shock. So what's going wrong in neurogenic shock? What's happening in his body? Neurogenic shock happens when a spinal cord injury, especially above T6, cuts off the sympathetic nervous system. The brain essentially loses its ability to send out those critical fight or flight signals. Here's where the spinal level really matters. The nerves that control the heart, the cardiac accelerator fibers, come out between T1 and T4. When the spinal cord gets injured above that level, the heart doesn't get the message to speed up or pump harder during stress. Additionally, because of this dysfunction of the sympathetic nervous system, the nerves that normally constrict blood vessels are also offline. So without those signals, arteries dilate and veins dilate. And unlike our sympathetic nervous system, the parasympathetic system is still working perfectly. So the vagus nerve keeps doing its job. It's slowing down the heart rate. So now we have unopposed vagal tone. And this is why our patient is bradycardic at 54 beats per minute instead of the 120 plus that we would expect in shock. Now, this is why neurogenic shock is so problematic. Let's review. Our blood pressure depends on two things: mean arterial pressure, which is cardiac output times systemic vascular resistance, and cardiac output depends on heart rate times stroke volume. In neurogenic shock, because of this lack of sympathetic activation and unopposed parasympathetic tone, everything falls apart. Heart rate drops because we don't have signals going into the cardiac accelerator fibers, and we have unopposed vagal tone from the parasympathetic system. Stroke volume drops because dilated veins mean less blood returns to fill the heart, and systemic vascular resistance crashes because the arteries are dilated and there's no vasoconstriction to tighten the pressure. So both sides of the blood pressure equation are failing. Cardiac output plummets and resistance crashes, and this is where our patient's mean arterial pressure collapses from every angle. How does this collapse show up? Well, we have significantly low blood pressure. We have a low heart rate, or a heart rate that's too normal for how hypotensive they are. The skin is warm because all the vessels are wide open. Neurological signs, of course, because we have spinal cord injury, so we can have flaccid paralysis, we can have sensory loss, we can have an absent rectal tone. And in men, we can note priapism. It's a subtle but important clue. Now, let's talk about treatment. Of course, our first step is spinal precaution. We immobilize the spine and prevent further injury. The second step is to consider fluids, but cautiously. We can give a small bolus of 500 to 1,000 mLs to assess how a patient responds, but we don't keep pouring fluids into these patients. These patients aren't volume depleted. The spinal injury has essentially cut off their sympathetic control. Their arteries are wide open, and their heart can't speed up like it should. More fluids won't restore the neural pathways that control vascular tone and heart rate, and giving them excessive amount of fluids can actually send them into fluid overload and can be dangerous. Where our treatment begins is vasopressors. The first line pressor is norepinephrine, and this is why it works so well. It stimulates alpha-1 receptors, and this tightens the arteries, raises resistance, and brings up the pressure that way. It also stimulates beta-1 receptors, which helps the heart beat faster and more forcefully. So norepinephrine gives you vascular tone and cardiac support at the same time. If norepinephrine isn't enough, dopamine is typically your second line agent. It has both alpha and beta activity and is especially helpful when bradycardia is prominent. Dopamine is more likely to cause arrhythmias, especially in trauma patients, so it has to be used with caution, and both response and side effects are very much dose dependent. For refractory cases, we should consider epinephrine, which has strong alpha and beta activity, and it's more useful when we need maximal support. We also consider phenylephrine, which is a pure alpha-1 agonist. It can be added if we need pure vasoconstriction without affecting heart rate. Also, let's not forget about atropine for severe bradycardia. What atropine does is it blocks the vagal effects on the heart. It allows the heart rate to increase that way. But remember, because it only removes parasympathetic brake, so to say, it won't restore the lost sympathetic function or fix the vasodilation. So it's specifically just to target the heart rate. One key thing to remember in spinal cord injuries is that the mean arterial pressure that we usually aim for is not the same. In most critically ill patients, we aim for a mean arterial pressure of at least 65 to keep the organs perfused. But in acute spinal cord injury, that's not enough. This is because the spinal cord is highly vulnerable to secondary ischemia, especially in the first few days. So our goal is a mean arterial pressure of at least 85, ideally for 5 to 7 days after injury. So let's apply this to our patient. His blood pressure is 82/48 and his mean arterial pressure is 59. This is far too low for spinal cord injury. We want the mean arterial pressure equal to or over 85 to preserve spinal perfusion and prevent further damage. Also, to note, with any case of trauma, just because someone has a spinal cord injury doesn't mean that they're not also bleeding or septic or in another form of shock. So, even though we're suspecting that this is neurogenic shock, so we still do our EFAST exam. That's our bedside ultrasound. We look for free fluid in the abdomen or pelvis, pericardial effusion, pneumothorax. We check for pelvic fractures. We get our chest imaging and assess for any signs of tension physiology. And of course, we get our labs. They help us rule out other causes and monitor perfusion. We draw lactate. When tissues aren't getting enough oxygen, they switch to anaerobic metabolism and produce lactate as a byproduct. Elevated lactate tells us that perfusion is inadequate, even in neurogenic shock. We check our hemoglobin and hematocrit because low levels can suggest blood loss. We check our ABGs for a base deficit because that can reflect how much acid accumulated in the body from poor perfusion. We also check BUN creatinine because that can indicate if the kidneys aren't getting enough blood flow. Check our troponin because bradycardia and hypotension can strain the heart, especially if there's chest trauma, and elevated troponin suggests cardiac injury. And of course, electrolytes. Spinal cord dysfunction can affect hormone regulation, and bradycardia can be worsened by electrolyte imbalances like hyperkalemia, for example. As always, we have to monitor our end organ dysfunction because despite the warm skin and different presentation, neurogenic shock patients develop the same end organ problems as any shock state when perfusion is inadequate. We look for urine output, and the goal is to be above 0.5 mL per kilogram per hour. We monitor our patient's mental status. We watch for confusion or altered consciousness from cerebral hypoperfusion. Skin perfusion, even though their skin feels warm from vasodilation, we can still check for capillary refill and look for modeling as perfusion worsens. The key point is that neurogenic shock may look different initially, warm and bradycardic versus our usual cold and tachycardic, but untreated, these patients will develop the same cellular hypoxia and organ dysfunction as any other shock state. Remember, neurogenic shock is a clinical diagnosis, but our imaging and labs help rule out mixed shock states and make sure that you're not missing something life-threatening that you can actually fix. All right, guys, this was our neurogenic shock lecture. I hope it was helpful. I hope you learned. If you liked it, please subscribe, press the like button, leave me a comment. I'll be more than happy to engage. If you haven't yet, you can go and explore our other shock lectures or any other lecture on Izzy Medicine. For now, thank you for watching, and stay calm and keep saving lives. Bye.